build off of her skill set that she had coming into group and just gain self-awareness, and then ultimately get to see her leave our facility. But let's talk about before she arrived in our custody. So she reports that about 75% of her friends engage in illegal activity. This is a question that we ask at intake during the eval portion of their time here. She also says that she uses drugs and alcohol while spending time with them. And she attributes a lot of the reason of that is she gets caught up in the thrill of just wanting more. And that's a reoccurring theme in group. And my co-facilitator, Kelly, is a licensed clinical addiction counselor. She'll often use the terminology they get just as addicted to that chaos, or they're comfortable with the chaos. And that's something that we saw with this person, is that she seemed just as caught up with the thrill of the chaos as it was the routine of the substance use or the using itself. She was just as addicted to the thrill of the lifestyle around the using as she was with the using. Her charges included unlawful possession of drug paraphernalia, and she had 2 counts of that, and she was sentenced to the Department of Correction for 18 months with probation and parole to follow. That's a typical sentence for someone with 2 counts of drug para. Also, she sat in county jail for a couple months prior to coming here, and she was hospitalized for 3 surgeries. Something that is interesting to note is that she also reported jumping off the 3rd tier of the jail and broke her leg. So the pod that she was in, she had jumped off the railing. A lot of times in jails, there are multiple levels, right? So whatever level that she was on, she had jumped off of. She's looking down. She'd taken a leap and fell from the 3rd tier, and ultimately ended up breaking her leg. And when asked why she did that, she states, "I just thought they wouldn't keep me in jail." Now, this is a very intelligent individual, and it just didn't quite sit right with me why she would have done that. And I suspected maybe there was more to it. Maybe what was her mental state at that time? Was there something else going on? And we never really got to the bottom of that. And if I were to suspect something was going on, could maybe say it had something to do with her detoxing from her substance, her substances. So that's kind of my guess. But she has never indicated that she's been suicidal. Definitely not when she was here. She was not suicidal. Never indicated that. Never stated those intentions, and so it was just odd for us to hear that. But that was her reasoning. I just thought they wouldn't keep me in jail. And sometimes as we know, substances can produce that effect when we are withdrawing from those substances. I always tell the ladies in group, opioids are really difficult to come down from. We might not actually be dying from the withdrawal, but it might feel like we're dying. And so that was the state of mind she often talked about being in when she was withdrawing, is I felt like I was going to die. And the frequency and the amount of substances some of those ladies were taking in, I wouldn't doubt that was what was going on at that time. Overview of substance use, though. She acknowledges that she used substances. Obviously, it was an issue for her. She was appropriate for treatment, and she had smoked about a half a pack a day, but also used fentanyl daily, and that was her substance of choice. She consumed opiates till she had blacked out or passed out. She'd also recreationally used meth and marijuana, but didn't drink since about 2021. And in the past 30 days prior to coming to prison, she states that she used. She also acknowledged that drug use has affected her life, whether it was employment, health, legal status, or her money and financial situation. It definitely took a toll on her situation. Her diagnoses: she was diagnosed with severe opioid use disorder, generalized anxiety disorder, and uncomplicated bereavement. And she did talk a little bit about witnessing the overdose of someone close to her, a friend. Um, it is not uncommon for someone to come into substance use treatment group and to have trauma. We know that the two go hand in hand. It's a very common co-occurring disorder, and it's something that often comes up in substance use treatment group at some point, usually in the later part of the group when the group is more cohesive and they're trying to lean on each other, trust each other, and try to work through some of those issues. So it wasn't uncommon to hear her talk about how that really affected her. And that was sort of her main her main her main issue and what she really wanted to work on throughout our group. Although she did not have a diagnosis of PTSD, and I thought that was interesting. A lot of ladies will come in with a diagnosis of PTSD, and especially if they're taking medications, which she's taking hydroxyzine. Um, Not ultimately, a medication where you're like, oh my gosh, that's associated with PTSD, or that's if she's on that medication, I bet there's a whole host of other diagnoses. No, not quite, but um, with the uncomplicated bereavement, you would suspect maybe there would be other diagnoses tacked on, but not necessarily because the I believe the event happened within it didn't happen too long ago, and so if this was her symptoms were to persist, I would maybe, and if she's still struggling with this, maybe talk to the provider and see if there's something more going on, and if she does, if she does meet criteria for another diagnosis. But for right now, that was what they came up with. She denies any current symptoms of anxiety, low mood, lack in sleep, trouble concentrating, loss of appetite. That was during her assessment, um, which in prison, in this setting, they do their assessment and it might be a while before they actually receive treatment. And that's different than in the community or in other settings, right? Where you do your intake, you do the interview with the LAC, and you get through that whole assessment process, and hopefully you get into treatment within a day or a couple days, but not quite the case in prison. So we do our assessment, but it's probably at least a few months before you do any sort of treatment. So um, what she reports during her assessment might not be the case by the time she's in our group. So we do have to take some of that with a grain of salt. Um, what's reported in the assessment and kind of do our own reassessment at the starter group. Self reports that she's never had SIs, suicidal ideations, and she denies history of self harm. History of past substance use treatment and mental health treatment. So she was treated for depression and anxiety at 16 years old. Substance use disorders, or she was evaluated 3 times and underwent treatment 2 times. But both of those were court ordered or they took place in a correctional setting. In group, she attributes a lot of her past failures and treatments as just stepping stones. And I think that's, I always commend residents for doing that. And that is something that's very difficult. It's hard to come by in a setting like this when someone's able to admit that a mistake or a failure is just a lesson That's a characteristic that, I always try to highlight in them is, um, because it's easy for a member to really get down on themselves or shift the blame and say, that wasn't my fault that I didn't complete that treatment. That wasn't my fault that I caught that charge. But to actually say, hey, yeah, I'll take responsibility for that, and I'm going to learn from that. That was huge, and I like to kind of make an example of that in group and say, hey, this is someone, or this is something that we can admire in someone, and we should all consider doing something like that. Or what is an area in our life that we can consider doing that? What was the last mistake, or when was a time in our life that we can think back to where we made a mistake but we learned from it? Client says that the previous attempts did not work, but she feels this one is different because she's gained different skills and learned different new pieces of information about herself. Yeah, we hear that a lot. This time's going to be different. Okay? How do we actually know that it's going to be different? And through our actions, obviously, and being a counselor in this kind of setting is unique too, similar to being a counselor in a residential setting, because this is residential where we can see what their behaviors are like by the end of treatment. So that kind of verifies it. Like, did they actually change? Well, let's see. What is their attitude every day in group? And also, are they receiving institutional incident reports here? Like, what is the staff observed on the floor? Those are the things that I look at when I'm saying, okay, has this person changed? Well, I can actually observe that here. In an outpatient treatment facility, it obviously has its benefits, but one of the downsides is that we don't get to observe those things every single day. We just get a glimpse of it during group or during our individual sessions. So, for educational and work life, she attended middle school but dropped out after 8th grade due to being uh, on probation. She was also placed in a detention center for at-risk adolescents. She never got her GED or graduated from high school, and so she did do GED classes while she was at DWCRC. Um, and she then planned to go to community college upon her release. That is one benefit of prison as well, is that if they don't have their GED or they haven't graduated high school, they have the option and are very they're kind of urged suggested that it's suggested that they get their GED before they leave here. Legal history: 28 prior convictions, and those all span from speeding to trespass, but she has no history of assault, violence, or any charges with a weapon or something violent like that. Her LSI score is 56%. That means that when she goes back out, she's got a 56% chance of reoffending or coming back to prison. The legal service inventory, the LSI, is a way that we can measure her recidivism rate. It also determines what her risk level is, and what her highest areas of risk are, so that we can identify needs and then hopefully target those needs and meet them. Sort of treat what is the riskiest areas in her life. Medical history: she's previously on methadone to manage her opioid use disorder, but no longer. And she did have pain in her limbs due to arthritis. Also, some poor dental health. She had requested to see the eye doctor and dentist while she was incarcerated. She had an injury to her limb, obviously due to that fall from the 3rd tier. Social history: she had a previous relationship with a 34-year-old male who's in federal prison. She had one child born on the reservation but taken by Child Protective Services. Sober supports include her dad. She talked a lot about that. Dad's dad's in recovery. She shared that in group, she often felt left out of those traditional ceremonies, Native American ceremonies, and would talk about how her siblings got to engage in those things, but that was not something that she got to do, and so that she felt like that really led to some of her depression and anxiety issues, and ultimately just that feeling of being left out might have contributed to some of her decisions growing up. She also talked about her environment, her family. It was not uncommon, like we see in a lot of Native American households, is that heavy substance use, and it was just normal to have drugs and alcohol around during gatherings and holidays. Her friends, so her own logic and reason was often replaced by that of her friends. So we see that too, is that no matter how smart someone seems to be and how able they are in making their own decisions for themselves, sometimes, depending on the group of friends that they're with, their own logic and reason goes out the door and is replaced by whoever they're with, depending on if that person is dominant and is able to take the lead and can sort of make that decision for her. And I think that's a lot of what happened when she was around a certain group of friends, who sort of dominated her and just made decisions for her, so to speak. And I think it really did depend on the relationship that she was in as well, based off of what she had shared in group. Um, Physical and emotional background. So she had witnessed that loss of a friend, but in the past year, she expressed no concern for her emotional well-being. But during group, and that's what was reported during the eval, but during group, she had reported experiencing a lot of grief from losing that friend. And she had talked about self-medicating with substances and how that helped with her coping, or helped her to cope. And so I did a little bit more research on this, and what is recommended, if that's suspected, right, is the use of the PHQ-9 along with the GAD-7 for screening tools. So both of those, a score of 5 to 9 points on either questionnaire, indicates mild anxiety and warrants referral to a psychiatric provider and or mental health counselor. Because there's something to be said about licensed addiction counselors practicing within their scope of practice. Right, we want to make sure that we are sticking within what we know and what is our specialty. And sometimes the situation, it warrants a referral to a psychiatric provider to make that more advanced call, or make that call that it might be more in their wheelhouse. And so if a score, or if someone is within that 5 to 9 point range, a referral might, that is something that we consider as well, even though we don't always use those screening tools like the PHQ-9 or the GAD-7. There's something that's striking within our assessment here at DWCRC. Our process is that we take it to the multidisciplinary case planning team meeting, and we discuss whether a referral to a psychiatric provider is necessary based off of the information we have. Our LAC typically does not diagnose co-occurring disorders beyond the substance use disorder. Typically stick within their scope of practice, and unless, of course, that professional is duly licensed. So I know different people have different thoughts on that, but that is sort of our protocol and what we do. And I'm of the opinion that that's kind of how it should be done. The ASAM dimension. So let's talk about that and the updated dimensions. Here they are. So the first one is intoxication, withdrawal, and addiction medications. 2, biomedical conditions. 3, psychiatric and cognitive conditions. 4, substance use related risks, 5, recovery environment interactions, and 6, person-centered considerations. So here they are. We can just go through each one. So the first one for her, we talk about intoxication, withdrawal, addiction, meds. Relatively low risk here, risk of 0 because she's incarcerated. And I mean, you can read what I put, but she has limited access to psychoactive um, substances, and she spent a considerable amount of time in prison. She has no trace of drug metabolites based off of what was indicated on the UA. And she was on MAT, but she no longer requires those services as determined by a physician, and therefore her risk rating is going to be 0. As for the second dimension, so biomedical conditions, she self-reports an injury to her leg stemming from an incident occurring at county jail. So make sure to put that in there, but also the medical department has scheduled several procedures to treat her leg. She lacks mobility, but does not require use of a wheelchair. She's not pregnant, denies having issues sleeping. Put a risk rating of 2 there. The reason being is, she's got prior issues with this one, especially with the leg, but because of her past issues that's carried out into the present, I think that sort of increases her risk more. So her pre-existing conditions, they didn't just stay in the past. These are things that continue to affect her today. It even required the use of a wheelchair. So that's why I rated her a 2 there. 3, she denies having any emotional and mental concerns in the past years. She also denies thoughts of suicide and self-harm. Mental health diagnoses include GAD, currently being treated with hydroxyzine. She does not have any delays or issues functioning. She does not report hallucinations or delusions. She's currently in 2.1 cognitive behavioral interventions for substance use, which is a treatment group. She is making appropriate progress in group, so I rated her 1. 4, substance use related risk. She is not at high risk to engage in substance use at this time. The environment she lives in is controlled and supportive, free from illicit substances, and I scored her out as a 0. 5, recovery environment interactions. She is able to function effectively in her current environment. She appears safe and expresses no concern for her safety. She is not engaged in any verbal or physical altercations while in custody. Really not much concern there, and so I scored her out as a 0. And then person-centered considerations. She currently does not have any barriers to care. She is engaging in substance use treatment without any issues. There does not appear to be any need for additional motivational enhancement therapy at this time to increase her willingness to change. She continues to engage in the group process to reach and advance her goals, and she is scored as a 0. Okay, so this is kind of what I came up with for her treatment plan. Level 2.1 substance use treatment. She is already engaged in that to address both her co-occurring anxiety and her depression, as well as her substance use disorder. And this type of treatment is a manualized treatment, but it does have flexibility to address some of those individual issues that she has going on, and to develop skills to manage those high-risk situations and high-risk people. Psychiatric monitoring and medication, so monthly appointments with the provider to address any needs that she has. Responsive risk reduction for women. This is a gender-responsive program to address trauma and reentry for women. And then one-on-one cognitive behavioral therapy, if we had the resources. I know sometimes in this type of setting, the counselor who comes on site is so busy with the caseload that she has, because ladies kind of flock to her and request her every opportunity they get. And so it's kind of a general understanding that, okay, we're not might as well not even request her because I don't know if she'll have time. And so they kind of get put on a waiting list and we'll have to see. But if the resource is available there and if the counselor has time to meet with her, I would consider putting her on for cognitive behavioral therapy, even if it were even just a few sessions to talk through some things. No harm in that, to recognize and adjust those negative thought patterns to change unhealthy behaviors. Then obviously, once she's done with 2.1 substance use treatment, recommending a lower level of care, aftercare in the community would never be a bad idea. In fact, that's what we do upon completion of that treatment. In their discharge summary, we recommend a lower level of care. And then just my last slide is just any questions. Well, I guess questions that I have for you. How much time do you usually spend talking about events that happen before the assessment that might be uncomfortable, such as like, why did you jump off the third tier of a railing? And then my second question, what other treatment recommendations do you have beyond beyond this one, beyond the responsive risk reduction, beyond the psychiatric monitoring, the level 2.1 in the cognitive behavioral therapy? And then my last question, who do you think is best suited to be a part of that treatment team? And that's all I got.